upcoming webinars. MedCan presents future webinars. The next one is the new 24-hour movement guidelines. Canada's first all-day movement guidelines have just been released. That was actually last week. And they feature important implications for the way we all manage our physical activity. Public health exercise guidelines used to limit themselves to suggesting a minimum of 150 minutes per week of moderate exercise. But as science recognizes the importance of physical activity for human wellness, the evidence suggests we would all benefit from incorporating movement throughout our days. In this complimentary webinar geared to lay people, MedCan Chief Medical Officer Dr. Peter Nord walks through the new guidelines released in partnership by the Canadian Society for Exercise Physiology, the Public Health Agency of Canada, Queens, and Pathophysiology. Pretty exciting webinar. So today's webinar is the good news on COVID-19. It's with MedCan's Dr. Peter Nord and Dr. Andrew Baker of St. Michael's Hospital. Gentlemen, you're both on the call with me. How are you today?
Very well, thank you, Christopher. Thanks for
Peter, how are you?
Yeah, doing great, Chris.
Okay, so I'm going to stop sharing. We're going to go off and I'm going to go through each one of your bios. So Dr. Peter Nord, who I think would be familiar to most people on this webinar, but Dr. Peter Nord is MedCan's Chief Medical Officer. Previously, Peter was a VP CMO at Unity Health Toronto. Dr. Andrew Baker is the Incident Commander at Ontario Critical Care COVID-19 Command Center. He's also the Chief of the Departments of Critical Care and of Anesthesia, and is the Medical Director of the Surgery and Critical Care Program at St. Michael's Hospital of the Unity Health Toronto. Dr. Baker, thank you so much for attending on this webinar. I'm going to let the two of you, we have a lot to get through, but the essentially the impetus for this webinar for the people just joining us is that we could use some good news on COVID, I think, and you have studied the first wave and analyzed the implications for the second wave. I'm going to hand it over to Peter to run this, but we're looking forward to hearing the good news on COVID-19. So Peter, take it away.
Great, thanks, Chris. Yeah, certainly fatigue is one way to say it. It's been a long haul, and unfortunately, we're only part way through. The forecasts are that this thing isn't going away anytime soon. And so we really need to hunker down and have a really long-term view of what life's going to be like over the next 12 to 24 months. And that's what we're identifying for all of our clients looking forward. It's been, a wave one. We're in wave two right now. Fully expect, if we look some of the models from Spanish flu and others, that a third wave might be possible in the springtime. Vaccines coming out, the efficacy, the true benefit of vaccines is still up in the air. The testing has been all over the map. Lockdowns have been all over the map as well. Some effective, not all of them effective. So we're looking for silver linings, and there has been a number of really great things, unfortunately, in some areas that have come out. And one of those areas is the medical science. We have learned a ton compared to 7 months ago. I was actually reviewing this video that was, and I'm not sure Andrew if you saw it, but it came out of Italy in mid-March, and there was an ICU intensivist that was giving kind of his version of in the middle of the crisis. So this is, if you remember what was going on in northern Italy, was extraordinarily scary. Hundreds of people entering the healthcare system, completely overwhelming their healthcare system. And he was looking back on it at some of the things that they were talking about. So they had, in that area of Lombardy, they had 800 ICU beds. 500 were suddenly taken up with COVID patients. They tried to increase those numbers as best they could just to handle the capacity and the demand that they were seeing. They were triaging people. I mean, it said at one point, 88% of the ICU patients were being intubated. Only 30% were being prone. They were saying, yeah, it seems like proning, the position of being prone was making a bit of a difference, but we weren't really quite sure. They were putting a lot of people from the emerge in the emergency department. If your oxygen saturation was dropping, they'd immediately put you on CPAP, which I think most people are aware of, sort of that for sleep apnea, kind of a CPAP machine. And then from there, very rapidly into ventilators, mechanically ventilators. That's where we stick a tube down people's throats and into their lungs, and they breathe. And the results that they were getting at that time was, 30% of the people, about a third were doing sort of okay. A third needed mechanical ventilation, and more than a third didn't do well, which means they basically died. And so we've learned a lot, even from the acute care management side of things, on how do we triage, how do we think about mechanical ventilation, how do we do hospitalization, how do we think about ventilation, how do we use our ICU beds in the most effective way possible. So scroll forward. That was sort of a glimpse of wave one, and now we've scrolled forward into wave two, which is very, very different from wave one. We've certainly learned a lot, not just on the medical side, but in terms of what public policies seem to work better than others. As of 10:30 this morning, we in Ontario have 274 hospitalizations, 72 are in ICU, 45 are on ventilator. When you compare the deaths during wave one and wave two, looking at the comparators, back in wave one, we were having 70 to 80 deaths per day. Right now, we have single digits, sort of 5 to 9 deaths per day. So very dramatic on that end of the spectrum, that tip of the iceberg. Back in wave one, we had about 50, at one point, we had 5,800 active cases with 1,000 people in hospital and 200 in the ICU on any given day. Scroll forward to wave two, guess what? The same number of active cases. So where we had 5,800 active cases, we have 5,800 active cases right now in Ontario. The difference is 274 in hospital versus 1,000 and 72 in the ICU versus well over sort of in that 200 range. And Andrew was having to live through this. So I just thought we would throw some of those numbers out just to frame the question and some of the learnings that have gone on. And Andrew, you've been in the heart of this from the beginning, both at the provincial level, from the command center perspective, and also you're there seeing patients every single day. So in terms of some of the things that you've been seeing, what's some of the good news that we've been seeing based on our learnings over the last 6 months or so?
Yeah. Well, thanks, Peter. Yeah, there's a ton of good news, actually. And I personally feel very different than I did at the same stage in wave one. And I think most of my colleagues feel very different. So just as an intro, as you know, Peter, I've been focusing on the ICU patients who are on life support machines. And so my world is skewed in that I look at a tip of an iceberg. And what's really interesting to most of us is, what's the size and the nature of that, what's below the water of that iceberg? What is that iceberg like? So maybe I'll start generally, which is that you're absolutely right. I think I was one of those people that watched Italian videos through March, and we just didn't know what sort of tidal wave was coming, and we were all very nervous about it. And so the big thing is, number one piece of good news is that we've lived through wave one. And not only has the public, but the healthcare system has. And so we're a lot happier about knowing how to take care of people. We're a lot safer. We know how to use PPE. We know how to manage patients, but not ignoring patients. Not that we did, but we're very comfortable in doing all the things we need to do, which is awesome. The second thing is that, in Ontario, we have a fantastic healthcare system, and we're lucky. And boy, did we ever learn how important that healthcare system was for non-COVID illness. And I think the good news is that we're determined this time to provide tons of non-COVID care. And that's got to be huge news, because what many of us worry about, Peter, I know you do and I do, which is inadvertently how many unnecessary diseases and deaths did we sort of not get to non-COVID related. And I think that's going to be a huge difference, and that's got to make a huge impact in a lot of, I know that affects many, many people waiting for cancer surgery and so on, right through to people waiting for arthritis surgery, But I think the other bits of good news are that we've learned a ton about medicine and science, and we've also disposed of some science that may not, and that's useful too, to know what doesn't work as much as what does. So As you know, Peter, we've learned that using dexamethasone, a steroid, is a very common steroid we've had around for a long time. Inexpensive, available drug. We now know that that's useful in people that have COVID and need oxygen, and certainly have COVID and need oxygen and need intubation. That's the that's the ventilator machine that is life support in the ICU. That dexamethasone actually reduces mortality. So that's huge. So we have a drug which reduces mortality. It's not useful in people that don't need oxygen, by the way. It may actually be harmful because you don't want to reduce your inflammatory response if you're not that sick. So we also know how to use it. So that's big. We also learned a lot about lying on your stomach. We used to put people on their stomach, Peter, who had really bad lung ARDS in the past, pre-COVID. So if we are struggling keeping people alive with a ventilator, we would often put them on their stomach, and it just changes the pattern of blood flow and of ventilation for a lung. So not only are we learning to do that in people on ventilators with COVID, but we're actually started doing that in patients even before they get to the ICU. So if you need oxygen and you're in hospital, we're having patients wide awake lying on their stomach and breathing that way, and that helps. We're also really now a lot better off at understanding when we can use things like CPAP, when it's useful, when it's not, other high flow oxygen. We're getting better at the infection control aspects of things. So while we do see some outbreaks, we're still far fewer outbreaks. So all these things, and I'll just pause after this, but all these things add up to what we're starting to sort of perceive as overall better outcomes and better control. And now I must say something about numbers though, Peter. You mentioned all those numbers, and of course, I get to see the tip of the iceberg. So we're also better at testing. And so we may have everything in life is a denominator issue, right? And so we don't know what the numbers would have been in wave one if we had tested more. And so it's hard to say what the comparator is today.
Yeah, for sure. There's no question. That's the that underneath the iceberg, and we've used that analogy a few times on different webinars. You can only see what's above the surface, and hopefully some of the serological testing, the antibody testing that some regions and populations have been able to ascribe to, will start to get a sense of who's actually been infected. I think one of the challenges that we've noted with this virus is the asymptomatic spread. And that's one of the reasons it's become a pandemic. That's clearly an issue. And that's something that I think that's that underneath the waterline that we have only hints at what that number actually looks like. And that may relate to, and maybe you could comment on this too, is the rate of positivity. Because I think a lot of people, they see that in the media as like, wow, we've got 20% of our cases are positive, or 0.1% of our tests that have come back are positive. Maybe you could just take a minute and talk a little bit of what, as you're looking at it from 60,000 feet, what does that change in the positivity rate? What does that mean?
Yeah, I mean, I think there's 2 or 3 variables there, Peter, as you know, and so it would be great if there was just one variable and we knew what it meant. And there's 2 or 3 variables hidden beneath one number. And so whenever you get into a conversation with colleagues, you'll mention one variable and someone brings up the other. But here's what it means to me. So if everyone were getting tested randomly, the positivity rate would mean the sort of general prevalence in the community. The trouble is that actually people are going to testing centers half the time when they feel bad. They're not all going just randomly. And so there is a bit of a bias towards people who are not feeling well and might have symptoms of COVID or been exposed. And so that would enrich in that number. But as a general sort of rule of thumb, I think that we would be very happy if the testing positivity rate was below 1%. And I think above 3% is the usual sort of trigger for public health measures to be taken. And I think once you get above 10%, I think that you really sort of have to take a close look. Having said that, I think that right now, as you know, there is a concern that we're maybe overusing our capacity. And so recently in Ontario, they've really tried to focus testing for people that are been exposed or have symptoms. And maybe as a gauge, they want to sort of enrich in that positivity rate. Now that we know that it's in the community, we sort of say, well, let's just focus on the patients that we need to. So what that means is the positivity rate today might be, and maybe should be, a different sort of index than it was 2 months ago when we were trying to screen the community. Now that we know what's out there, we want to focus on the positive cases as much as possible. And so positivity rates around, I saw somebody say recently, maybe we should have them around 10%. Maybe that would represent or reflect really good education of the public. Don't come to get tested unless you have symptoms or unless you've been exposed. So anyway, so there's two uses there, Peter, and I think it's important to sort of, again, understand the difference.
Yeah, that's what I'd ask, because it's a lot of people have been asking those sort of questions. Yeah. It is complicated. It isn't easy. There's a numerator issue and there's a denominator issue for sure. And just we were just talking about ARDS. I'll just, for the audience, that's acute respiratory distress syndrome, just so that we don't use too much jargon. And that's maybe more good news in terms of what we've learned that works and doesn't work. Maybe you could talk about both remdesivir on the one hand and hydrochloroquine on the other.
Yeah, well, I mean, I think the remdesivir story has been really interesting, and it's been very tempting. It's a sort of antiviral agent, and what's exciting about it was that initially it looked, and it may still reduce the length of stay of patients in the ICU. And so there was arrangements made for doses to be available in Ontario. There's a limited supply, but we were going to get doses. Just last Thursday, as you may remember, the World Health Organization released some scientific studies and data to suggest that, unfortunately, remdesivir is not reducing mortality. And so we still have to figure out the best use of it. Certainly reducing time in ICU, you would think would affect mortality. It hasn't seemed to in those studies. So I think the jury is still out on the usefulness of remdesivir. So that it doesn't do harm. It may reduce length of stay in the ICU. We haven't had a signal for mortality. Hydrochloroquine, on the other hand, that has some important side effects. And one of the side effects is very relevant to many of us, which is that it can result in heart arrhythmias, or at least not tolerating heart arrhythmias very well. And so on balance, it's not really effective, and it may actually do more harm than good. And so I think for most of us, we've closed that sort of question off.
Yeah, I think that's, as you said, in terms of the good news over the last 6 months, what we've learned, that we can discount some things, take them completely off the table, and other things that have actually shown some promise. But it may be another 6 to 12 months before we can actually say the verdict is in. The jury's out until we have had more time. These things, and I think a lot of people think that these things happen very quickly and that we can turn around a study in weeks. And, typically in, any sort of study with anything like what we're talking about has come out in over years, like the really valuable information. It's really taken years. So I think we need to remind people that, Rome wasn't built in a day, that the really good, solid learnings take time. We're dealing with human beings with immune systems, and you just can't rush that. You can't rush it through a lab. So we're learning as we go. The epidemiologists are learning. The folks that are involved with public policy are learning. What measures work, which measures don't work.
I think the other thing, Peter, that is very relevant for you and me. You and I see patients, and we have to translate all of that scientific reading into an individual patient. And the trouble is that you and I face is that it's very different, I think, than people reading, stuff in the media and so on, is that there's so many ways for numbers to play games. We've talked about denominators here today. We've talked about shifting things, all sorts of things. And so when a single study comes out that looks really fantastic, you and I are very interested, but we also just sort of keep it in perspective because we often need to triangulate that study with other studies, and it's a while before, and there's a reason that people like you and I are conservative in that sense. It's very tempting, when you read the internet, which is a good source of information for sure, to sort of jump on one study and say, we've got the answer. And because we all hope that's to be the case. And I think that's the big difference that many people come to me and sort of are frustrated that I'm not quite as, ready to change on a dime. I'm sure you find that.
Yeah, I think we probably share that same view. The highs are probably not as high as we think, but the lows aren't as low either. So we kind of live in that happy neutral territory. And even on previous webinars, I've discussed sort of the bell curve of population studies. But as an individual patient in front of us, we don't know where that patient's going to fall. They could fall in the tails, or they could be right on the median. Chances are they'll be somewhere near the middle. But in counseling patients and families, it's always hard to say. It's like, well, we can tell you if there's 1,000 people on average, X will happen, but you might be X plus 1 standard deviation or X plus 2 standard deviations out into the tails. And at this point ahead of time, it's really hard to know. So that's always a tough one, but we have to respond to the big studies, and then we have to use a bit of our own intuition and a bit of the art of medicine when we're applying that to an individual case, somebody that's in front of us, in your case, on a ventilator in front of you, for sure.
Speaking of that, I think there's lots of things which we have learned which aren't out there in studies. And so one example, just so you talk about the art of medicine, I think now we have developed much better instincts. And I know of interest is coagulation issues. And so it used to be that a lot of coagulation and blood clotting issues would be somewhat occult or mysterious, or we wouldn't actually pick them up. We wouldn't know why somebody is, say, short of breath. And we wouldn't always think of a pulmonary embolism, a blood clot going to the lung, or other things like that, or even a small stroke. But in the context of COVID, when COVID is common in the community, if you're an emerge doc now and you get something strange that is related to blood clotting, I think now sort of clinical acumen sort of points to, so you've got to think about COVID early, and you've got to think about treating that blood clotting early. And so I think that, again, another piece of good news is that people were showing up with even fatal blood clot issues. Now we're jumping on them a lot earlier. And there's no study that tells us that necessarily, but these are some of the many things where we're able to make a difference.
Yeah, certainly it seems that COVID, while initially was purely a respiratory issue, now seems to be more of a vascular issue that happens to affect the lungs. Any more recent work on that come out of the last sort of month or two?
For sure. I think that it's about where the ACE receptors are, the angiotensin converting enzyme. It's just a fancy name for a type of receptor. And the viruses seem to have hijacked that particular type of receptor to get the entry into cells. And so as you know, the body is full of cells, and on the surface of those cells are all sorts of receptors. That's how they interact with their environment. And so what we're sort of learning in medicine now is we're really rethinking the taxonomy or the organization of disease. And it used to be you'd get your medical textbook and the first chapter be on lung and the second chapter on the heart and third chapter on the liver type of thing. And now we think that maybe diseases are better organized by different types of physiology or receptors. And this is a prime example that COVID may turn out not to be a lung disease per se. It may be an ACE receptor disease, which could be, so then you sort of say to the anatomy people, well, where do I find ACE receptors? And sure enough, they're in the lung, the heart, the kidney, and we see about 20% of really sick patients getting dialysis. And unfortunately, they're also in the brain. And so we see some people with brain impacts. So again, the good news there is the understanding of pathophysiology and knowing that we look beyond the lung to other organs that have this receptor. And so it's really It's really that type of disease, not a lung disease.
Yeah, that's a very important takeaway. And maybe closing out, I was lucky enough to hear one of your presentations, and one of the big takeaways that I brought from that was that the people in our populations that don't do well because of the accumulation of comorbidities or other conditions. And so, that tends to appear in older adults. As we age, we tend to have more chronic conditions that make us not necessarily more susceptible to catching the virus, but if we do get infected, we don't do as well, and we end up in hospital and ICU or on a ventilator. Maybe you could just speak to that for a second, because I thought that was really interesting.
Well, by the way, I mean, I am really anti-ageist, meaning that we have a lot of 80-year-olds who survive COVID in the ICU. And I sort of think of age as just the amount of time you've been running across the field in between the, in the gunfire sort of thing. So there's nothing wrong with being old. It's just you've spent more time, and so you're more likely to collect, one of those bullets. And so the same thing could happen to you when you're 40. If you stayed 40 for 20 years, if you can imagine that thought experiment, you just have 20 years of maybe catching one of those diseases. And so that's the only thing wrong with being old, by the way. Otherwise, you're fine. But having said that, Peter, you're absolutely right. That if there are people with chronic conditions such as diabetes, obesity, heart disease, and lung disease, they seem to be tolerating the COVID worse. And certainly there's a couple of reasons for that. The one reason, of course, is that we all rely on redundancy and reserve. So when we have inflammation and stress on the body, every system, the lung borrows from the heart and the heart borrows from the kidney. And when you take away that reserve in many systems, that borrowing system doesn't work anymore. And so you're more likely to just dip below that threshold of being able to survive. The second reason is, I don't know. Meaning, I wouldn't want to assume it's just that. There could be another reason that, that diabetes impacts something to do with the inflammatory system, that obesity impacts something to do with the inflammatory system. So I never like to assume that we know the end of the story, and that's what keeps medicine so fascinating.
Perfect. Well, maybe that's a good place to stop, and maybe we'll just hand it back to Chris to close out.
Andrew, I love that metaphor about the thought experiment and about being 40 relative to 80, that it's not age per se. And I think that's a wonderful motivator to engage in a healthy lifestyle, because you're less likely to, correct me if I'm wrong, but you're less likely to catch a bullet if you're engaging in the proper behaviors all the way through your life, right?
Well, I think, sure. I think the first point is the more time you spend out there in the field, the more likely you're going to catch a bullet. But if you do catch a bullet, I think that there's nothing per se wrong with being 80, but I do think that if you did nothing, your cardiac output would slowly diminish, your muscle mass would diminish. And so I think that maintaining your general health, and to sort of have that curve as we all sort of think about it, staying healthy, one day you don't wake up fine. But if you can stay healthy, you're going to tolerate a lot of things a lot better. And so I do think there's a huge benefit to maintaining a healthy lifestyle, and maintaining that cardiac output, maintaining that muscle mass, while you have to spend 40 years dodging bullets, sort of thing.
Mm-hmm.
Okay, so we do have some questions. Dr. Baker, you took the one about blood clotting. So I think we have about 3 more questions. So I'm going to run through the summary, which means, I'm sorry, folks, but I have to enter full screen. I have to do this. There's no way to. Okay, perfect. So the current situation. No, I haven't started slideshow yet. Sorry about this, guys. View slideshow. Okay, current situation, and we will distribute this in the email that goes out as well. We'll distribute the deck. High case counts for people in their 20s and 30s, likely to be followed by higher case counts in the higher decades. Younger people are not sick enough to require intensive care. That's currently, but ICU case numbers are ticking upward. To see one potential future for Canada, watch what's currently happening in Spain and France, and we don't know what the new case fatality rate is going to be. So the good news, this time we're not flying blind. We've learned some methods that work to decrease severity of COVID and improve outcomes. Dexamethasone reduces mortality, but only if your illness is severe, only if your case is bad enough to require oxygen. People with mild COVID, that is people with COVID who don't require oxygen, should not be given dexamethasone because it makes them more susceptible to infection and actually increases mortality. Okay, remdesivir reduces length of stay in ICU, but recent evidence suggests it does not reduce mortality. We know a lot more. When I say we, I say medical professionals. I'm not a medical professional, but medical professionals know better now how to care for COVID with respect to things like prone position. And we all have a lot more comfort with our care in our PPE. So the final point, while we have improved our ability to care for COVID, these are incremental differences. We have not yet found a game changer that definitively affects case severity or case numbers. We remain at the mercy of Mother Nature. So Dr. Baker, I'm gonna let you handle this last one, because when you and I spoke in our preliminary pre-interview about this webinar, can we say definitively that you are less likely to die in the second wave compared to the first? I'm gonna hand that to you, and then we'll use that as a segue into the questions. So can we say definitively that you are less likely to die in the second wave compared to the first?
Yeah, I think we can say, we might be able to say something very close to that. And of course, those of us who are fascinated by numbers are always, our ears are pricked. The case fatality rate may be lower. And we don't know that yet to be certain, because a lot of the patients who might die are still in the ICU. And so we don't know yet. We're starting to see some of that signal around the world, and we wonder about it. The question is this a denominator phenomenon? Is it that we've seen so many more young people with it that our percent mortality is lower? Was our percent mortality higher in the first wave because people who were susceptible got it and died? So what we really want to know, Christopher, and I'm not going to be able to answer, which is that if you're 40 years old and healthy, or if you're 60 years old and healthy today, are you more or less likely to die than you were in the first wave? My instinct is that you're less likely for a number of reasons. All the reasons that we talked about, the healthcare system is well primed to take care of you. We've got things like dexamethasone to treat early. We know how to use proning. You're more likely to get good access to good healthcare early. And again, I think that I think that comorbidities and being healthy now still makes a difference. And finally, it could be that these viruses do migrate in their lethality, and so we're still wondering whether that might be the case.
Fantastic, thanks for that. Now we'll switch to the questions. So someone wrote in, I'd love to hear your point of view on the combo of, and I'm not sure I'm going to get the pronunciation correctly, but ivermectin, zinc, and to a lesser extent, Zithromax or other similar antibiotics, especially when taken early. Second part of the question from the same person, especially importantly, why are there seemingly no PCTs on this? PCT, patient care technician? I'm not sure what
PCT probably.
Maybe it's, okay, randomized control trials. Okay.
Peter, maybe that's one for you, since that's one you.
Yeah, so we're actually doing a prospective case cohort study looking at the serology, so the antibody testing to see how on average versus the individual, what's the immune response like to somebody who's tested positive by PCR to COVID-19. So we're just starting that work right now, and hopefully we'll add to the body of literature about that. But I think the first part of the question, I'll bounce back to Andrew, just closer to that cocktail of drugs, because I've heard about it in the media, but I'm not the expert in that area for sure.
Yeah, I mean, so I try as much as possible to not have an opinion. In fact, especially on things which may I especially like to be open-minded. but at this, so part of that though is a commitment to evidence, so I just don't think there's sufficient evidence for me to say one way or another. And why we don't have more RCTs, I don't know. I know that being involved in research myself, there are a lot of very excellent research studies going on, and frankly, at our place, there was more research than there were patients available to participate in. And certainly over the summer, a lot of research slowed right down because there weren't new patients to enroll. There are places in the world which there are, of course, and I'd love to see that evidence. And I mean, I think that all these things have some type of promise because, of course, one of the issues that we sort of made mention to when we talked about comorbidities is that one of the problems with these viruses is not so much the virus itself, but the body's own unmitigated inflammatory response. And don't forget, we all have an inflammatory response to injury, and it's really our ability to modulate that, which is central. And so an unmodulated, overactive immune response is often what kills us. And part of what kills us then is that inflammatory response opens up our barriers, say that our membranes in our lung, and makes us susceptible to infections from everyday bacteria. And so sometimes some of these drugs that you're talking about, the antibiotics in this cocktail, which are there, may be helpful because they decontaminate some of the usual bugs and allow us not to get sick from everyday bugs when we have an inflammatory response. And certainly that's an idea in ICU, selective decontamination of the airway tract and the gastrointestinal tract. And that is promising as a strategy. And so maybe I'll leave it at that, Christopher.
Fantastic. Good news on the vaccine. Is there to either one of you? I think we can throw this to either one of you. What are you hearing?
Peter?
Well, I'll jump in. So I have a particular view on the vaccines. Number one, wait until they arrive. Like if we think the media headlines have been wacky over the last couple of months, wait till the vaccines really hit. It's going to be the Wild West. It's going to be a gong show because you're going to have the very first time that someone gets sick, the anti-vaxxer crowd's going to say, see, we should never do any of this. And that's going to grow. And there's going to be this idea that's been put out there that, the vaccines are the holy grail. And once it's here, we're all good. We're going back to life as normal. And people just really need to understand that the effectiveness of the vaccines, even in the best case, is not going to be great, that we don't even really know on large scales because of the emergency use authorization process in the US and other countries. The way that the approval process is going is be safe, don't cause adverse effects, and show some benefit, but not necessarily the transmissibilities. Those studies are probably years in the making to know, like, does it actually stop transmission? We can say, oh, it creates an immune response in an individual, but does that actually translate to actually stopping transmission? We won't know that for quite some time. So it's going to be craziness when the vaccines start to come out. This is big business. This is big pharma. This is politicking at its highest in the States, obviously, but in other countries as well. So, unfortunately, it's not very sexy to say, but it's the basics that are going to get us through this. I happened to watch a show a couple of weeks ago, and they asked some experts, would you rather have remdesivir or a mask? And the expert, and any hospital expert is like, I'll take a mask any day, because as we were finding out, some of the treatments are only for the sickest people. It's the simple things. It's distancing, it's hand hygiene, it's staying healthy. All of those are the things that are going to actually get us through the next year or two until we can really get this coronavirus down to kind of a dull roar. And so the idea that the vaccines are going to be the Hail Mary, is uniquely media related, and those fans are being those flames are being fanned very, very strongly, and that's only going to increase over the next couple of months. So be wary.
Okay, I don't know if I can challenge one of you to give a 1-minute answer, but what do we know about long haulers and the outlook for their health for the long term?
You probably want to define long haulers.
You're talking about patients who have persistent symptoms at the 6-month mark.
That's right.
Oh, yeah. So I think there's all different types of long haulers. And unfortunately, there's some patients who have injured lung from the chronic inflammation that's fibrosed right down. And I think those people are going to struggle because they have reduced lung function. And we know that from previous causes of this lung inflammation called ARDS. I think the people that go on to have fatigue, who have normal pulmonary function tests. There's a group of people that have a type of chronic fatigue syndrome and concentration, other neurologic effects. I think I'm more optimistic about those because I think we're learning more and more about plasticity even in the older age groups, and I do think that there's a hope for them. But again, we don't know. And you asked my opinion. That's my opinion.
Fantastic. Thank you very much to both of you. So we're going to wrap up now. Thank you to webinar attendees. Thank you, Dr. Peter Nord. Thank you very much to Dr. Andrew Baker, who you've been generous with your time and you've been frank and impressively, you've given answers that are understandable to lay people, which for people in your position can be challenging. You're very good at it. So thank you very much. Future webinars. So November 3rd, Tuesday, we have a webinar, the new 24-hour movement guidelines. And to register for that, that's bit.ly/movement_webinar. That's going to be a great one. That is it for today. Thank you very much.